Good morning, all. A warm welcome to the Young Physicians Forum and the CCP College lecture for the month of October 2022. Today's session will have two senior registrars, two of our very bright young senior registrars making presentations, as well as the college lecture which will be carried out by a member. To start with, it is my pleasure to invite Dr. Vipuli Kobbagala. She is a senior registrar in medicine at the National Hospital, Kandy. Dr. Kobbagala, over to you to make your presentation. Thank you.
Good morning to everyone. I'm Dr. Vipuli Kobbagala, senior registrar in general medicine, working at National Hospital, Kandy. First of all, I would like to thank the CCP for giving me the opportunity of speaking in this prestigious forum. The topic for today is the wicked problem, polypharmacy in elderly. What is a wicked problem? A wicked problem is a problem that is difficult or impossible to solve because of incomplete, contradictory, and changing requirements that are often difficult to recognize. Wicked problems are characterized by difficulties in defining problems, difficulties locating problems, difficulties identifying the actions that might narrow the gap between what is and what ought to be. So, the objectives of my lecture is review how polypharmacy becomes a problem in elderly patient population and summarize the possible strategies to reduce polypharmacy. At a glance, today, almost 1 in 10 people are over 60 years old. By 2050, 1 in 5 people will be over 60. The number of older adults has been constantly growing around the globe. Occurrence and concurrence of chronic diseases increases with age. The amount of medication use increases correspondingly. What is multimorbidity? Multimorbidity is defined as presence of 2 or more long-term health conditions, which can include defined physical and mental health conditions such as diabetes or schizophrenia, ongoing conditions such as learning disability, symptom complexes such as frailty or chronic pain, sensory impairment such as sight or hearing loss, and alcohol and substance misuse. Multimorbidity increases markedly with age. In a Scottish study, multimorbidity was prevalent in 81.5% of individuals aged over 85 years or over, with a mean number of 3.62 morbidities. Despite advances of pharmacotherapy, the availability of clinical guidelines for older adults with multiple morbidities is limited. Consequently, patients are often prescribed several medicines recommended by a number of specialists using disease-specific guidelines, which in combination makes the management of single disease is challenging and may even lead to patient harm. What is polypharmacy? A systematic review conducted in 2017 found a total of 138 definitions. There were 111 numerical-only definitions, 15 numerical definitions, which incorporated a duration of therapy or healthcare setting, and 12 descriptive definitions. The most commonly reported definition of polypharmacy was the numerical definition of 5 or more medications daily. Only 6.4 of articles classified the distinction between appropriate and inappropriate polypharmacy, using descriptive definitions to make this distinction. So, what is the definition of polypharmacy? There is no generally accepted definition for polypharmacy. According to WHO Technical Report on Medication Safety in Polypharmacy, polypharmacy is the concurrent use of multiple medications. Although there is no standard definition, polypharmacy is often defined as the routine use of 5 or more medications. This includes over-the-counter, prescription, and or traditional and complementary medicine used by a patient. So, having no definition that fulfills the first criteria of Pickett problem. What is appropriate polypharmacy? Appropriate polypharmacy is present when all medicines are prescribed for the purpose of achieving specific therapeutic objectives that have been agreed with the patient. Therapeutic objectives are actually being achieved, or there is a reasonable chance they will be achieved in future. Medication therapy has been optimized to minimize the risk of adverse drug reactions, and the patient is motivated and able to take all medicine as intended. Inappropriate polypharmacy is present when one or more medicines are prescribed that are no longer needed, either because there is no evidence-based indication, the indication has expired, or the dose is unnecessarily high. One or more medicines fail to achieve the therapeutic objectives they are intended to achieve. One or the combination of several medicines cause adverse reaction or put the patient at high risk of adverse reactions because the patient is not willing or able to take one or more medicines as intended. What is the prevalence of polypharmacy? Imprecise and heterogeneous definition of polypharmacy complicates the analysis of its prevalence and impact on relevant health outcome. While its true magnitude is unknown, the prevalence of polypharmacy is expected to rise. So that fulfills the second criteria for a Pickett problem. What are the reasons for polypharmacy? Older people often require multiple medications to treat multiple health-related conditions. Patients with multiple comorbid medical conditions also require numerous medications to treat each condition. Hospitalization also puts patients at risk of polypharmacy. Medicines are started and stopped quite frequently during patient hospital stay. Multiple doctors are prescribing medications for the same patient. Once a patient starts on the medication, it's never discontinued. Multiple specialists care for the same patient, each focusing on single organ system. Inadequate frequency of quality of medication. Lack of patient education is the most common reason. Doctors do not inform patients, or patients do not ask questions. This is the graphical explanation of causes of polypharmacy. There are patient factors and systemic factors, as I mentioned previously. Patient factors are chronic condition, complex drug therapy, and psychosocial factors. Systemic factors are multiple prescribers, multiple pharmacies, which lead into prescribing cascade. What is prescribing cascade? Side effect of one drug is interpreted as a new symptom, and another drug is started to treat that side effect. This is a prescribing for leg pain. The patient was started on NSA, that has developed heartburn, and patient was started on PPI. And due to NSA, patient has developed leg edema. Patient was started on diuretic and PPI, and both PPI and diuretic has led to hypomagnesemia, led to muscle weakness, and also diuretic causing orthostatic hypotension, ultimately causing falls. When I go through the literature, I found some common prescribing cascades. I want to share them with you. Ibuprofen causing hypertension, ending up with antihypertensive therapy. Metoclopramide ending up with Parkinson, starting Sinemet. Amlodipine, that is a very common one in our practice, causing edema, starting on fusamide. Gabapentin also causing edema and starting on fusamide. Ciprofloxacin causing delirium, starting on antipsychotics like risperidone. Lithium causing tremor, starting on propranolol. Bupropion causing insomnia, that lead into starting on mirtazapine and other antidepressants. Donepezil causing urinary incontinence, resulting oxybutynin, sorry about the spelling mistake, treatment, and amiodarone causing tremor, which lead to lithium therapy, and venlafaxine causing tremor, and diazepam. And with pethidine, patients develop delirium, leading to antipsychotic therapy like risperidone. Beta blocker causing depression, leading to antidepressant therapy. Amitriptyline causing decreased cognition, leading to donepezil. And narcotic causing constipation, starting laxative or laxative-induced diarrhea, requiring Imodium. And lorazepam causing morning drowsiness, which lead to caffeine intake. And enalapril, that is a common one, causing dry cough, bradykinin-induced cough, patients starting on cough syrup. And furosemide causing hypokalemia, starting on KCl replacement. And omeprazole causing low B12 levels and B12 supplements. These things are common in our practice. If we are vigilant, we can detect them and prevent and stop prescribing cascade at that point. So what are the clinical consequences of polypharmacy? Adverse drug reactions, drug-drug interactions, drug-disease interactions, poor compliance, increased hospital admissions, and increased mortality with hazard ratio of 1.27 to 2.23 and increased costs. When increasing number of medication, the number of adverse effects increase proportionally. Any new symptom is an adverse reaction until proven otherwise in elderly patients. Altered physiology elderly increases adverse reactions. And worsening of geriatric syndromes like cognitive impairment, delirium, falls, and incontinence. And ultimately, that compromise quality of life. If you go through our pharmacodynamics in elderly, polypharmacy affects absorption by drug binding interactions, such as drugs like zinc, calcium, iron interact with absorption of medicine, like thyroxine and andronate. And distribution, when we grow older, when we become elderly, our body fat content rises and water content reduces. And also with malnutrition, we have less protein. They have less protein to bind drugs. Metabolism with around 40% reduction of liver blood flow and liver mass, and reduced enzymes. They have less fast metabolism, especially drugs like benzodiazepine and warfarin. And but drug interactions are common in elderly. Elimination is low with reduced creatinine clearance. Also, creatinine clearance also become difficult to interpret with low muscle mass. When we consider pharmacodynamics in elderly, organs become more sensitive to drug effects. For example, reduced baroreceptor response with treatment with diuretics, processing drugs like AC inhibitors and ARB, patients develop postural hypotension, and that leads to falls and hip fractures. On the other hand, increased sensitivity to anticholinergic effects in CNS from drugs like antihistamines, anticholinergic, tricyclic antidepressants, and muscle relaxants, that leads to dry mouth, urinary retention, constipation, confusion, and delirium. Other problem is drug-drug interactions. When we prescribe more drugs, they react to each other. By that, can decrease action of drugs, increase action of drugs, and cause adverse effects. And drug-disease interactions. Some drugs interfere with disease. These patients have multimorbidities. When we prescribe one medication that can interfere with these diseases. For example, NSAIDs can interfere with heart failure and other drugs in this slide. So that leads to this cycle: age-related multiple disease, age-related physiological changes, and impaired functions of organs like liver and kidney leads to altered response to drugs. And that leads to increased incidence of adverse drug reaction. On the other hand, age-related multiple diseases requiring polypharmacy increases incidence of adverse drug reaction. So, what is the solution for this wicked problem? Experts have recommended patient-centered polypharmacy process. Here we have to assess patient, define context and overall goals, and identify medicines with potential risk and assess risk and benefit in context of individual patient, agree actions to stop, reduce dose or continue to start, and communicate with all relevant parties, patient, caregivers, and managing team, and monitor and adjust regularly. When we prescribe, even in elderly, we have to do rational prescribing. Whenever we prescribe, we have to go through this rational prescribing process. Then, why should we review medications in older people regularly? As I mentioned, because of increase in comorbidities with age and with physiological changes, they are susceptible to polypharmacy, drug interactions, adverse drug reactions, prescribing cascade, poor compliance, and potentially inappropriate prescribing. What is medication review? A structured critical examination of a person's medicine with the objective of reaching an agreement with the patient about treatment, optimizing the impact of medicine, minimizing the number of medication-related problems, and reducing the waste. That is the National Institute of Clinical Excellence nice definition on medication review. Medication reviews are widely used to address the inappropriate polypharmacy globally and recommended by many polypharmacy guidance documents. The main purpose of medication review is to improve the appropriateness of medications, reduce harm, and improve outcomes. To do that, there are many tools available to support us. There are BS criteria, which was developed by American Geriatric Society, which was updated 6 times and recently in 2019, that identifies potentially inappropriate medication that at risk to be avoided in older adults, and stop-start criteria, version 2 developed in 2015, medications to avoid stop and potential prescribing omissions is start in older patients. For benzodiazepine, as an empower tool for tapering benzodiazepine, and medication overload launched to educate patients, and to assess patients' adherence, we can use things like Morisky medication adherence scale. This is 2019 AGS BS criteria. There is a pocket guideline which can be downloaded, the 6-page pocket guideline which can take a printout and easy to use. Stop-start criteria. And we have the luxury of using modified stop-start criteria for Sri Lanka, translating to a resource-limited healthcare setting by Delphi Consensus, produced by our leading pharmacologists. This is the Empower benzodiazepine tailing off regimen picture. And this is Morisky medication adherence age criteria tool, which is easy to use. Now we talked about rational prescribing, medication reviewing. Next step is deprescribing. What is deprescribing? Deprescribing is the complex process needed to ensure the safe and effective withdrawal of inappropriate medicines. The medication we have to consider, is the medication required for current indication? Is the medication harmful to the patient? Is the patient happy to continue taking the medicine? But there are many barriers for this deprescribing. Resistance from patients, families, and carers. They may say she has always taken this medicine. The specialist said that she can never come off this medicine. We tried that before and it didn't work. Likewise, there are many barriers. Also, prescribers worrying about stopping the medication ordered by another prescriber or worry about the adverse effects from stopping the medication. Reviewing medication for potential deprescribing requires extra time to explore previous records, history, interview staff, and communicate and document rationale to patients, carers, and families. If we can overcome these barriers, we can achieve medicines optimization, reduce adverse effects, especially in elderly, and reduce hospital admissions, reduction in inappropriate medicines, patient prescribed medication in line with local formularies or guidelines, and collaboration with patient in their care, and regular reviews with the patient to check. For that, we can incorporate regular reviews with the patient to check adherence and suitability. What are the evidence for deprescribing? There is little guidance for the process of tapering, withdrawing, discontinuing, or stopping medications in all adults with polypharmacy in general clinical practice. Deprescribing appears to be feasible intervention, but may not affect the mortality. Evidence exists to guide deprescribing individual medications in carefully defined scenarios, and deprescribing needs to be considered for older people as a routine component the ongoing medication review process. So, still we can deprescribe with using these medication tools, and we can reduce the polypharmacy burden. Whatever we prescribe will not work if patient is not taking. Here comes two words, compliance and adherence. What is compliance? The extent to which the patient behavior matches the prescriber's recommendations is compliance. Adherence describes the extent to which patient's medicine taking behavior matches agreed recommendations from the prescriber. So we have to assess patient's adherence in each encounter, and we must empower patient to adherence, and if there are any barriers, we must address then and there. So there are steps to consider in polypharmacy management. Know when to stop and when to taper slowly. Involve the patient in decision. Offer safe alternative therapies. Get patient and family involved in monitoring. Involve team members. Include non-pharmacological approaches. Provide reinforcement. Be upfront about the need to withdraw slowly and monitor for adverse events, as well as how. Keep the message clear and say it often. Follow up and document the progress. Make several attempts at withdrawal and use variety of educational media. Empower patients to avoid future problems. So, these are the possible strategies to tackle polypharmacy, the wicked problem. Rational prescribing at initiation. Keep medication lists short and sweet. Start low and go slow. Know every drug, for every medication, know every indication at every time. Deprescribe unnecessary medication and optimizing drug therapy at each encounter. Assess and implement measures to improve compliance. Recently, Mayo Clinic Proceedings published this polypharmacy management in all the patients, which I'm not going to go through. You can use this initially when you go do the prescribing. Managing polypharmacy is a balance between providers' healthcare goals and patients' healthcare goals, and balancing adverse events and geriatric syndromes, patients' preferences for treatment. These are my references. Thank you.